Changing your behaviour is hard. We all know what we should do, eat better, exercise more, but just knowing what you should do doesn't guarantee that it will happen. But changing behaviour is not just about New Year's resolutions. When we introduce new things into a healthcare setting, when we say that best practice is now to do something new, then all the healthcare professionals have to change their behaviour too. They have to stop doing things the old way and start doing things the new way, and this can be a challenge as well. So a few years ago, a new screening test was introduced for Lynch syndrome. Lynch is a hereditary cancer that puts carriers and their families at a high risk of bowel, endometrial, and a range of other cancers. So diagnosing it early can save life, and it's really important. So the new best practice was that people flagged as having a high risk of Lynch syndrome should be referred to a genetic service for further assessment and management. So we looked at screening test results and referrals at 2 large hospitals in Sydney. And we found that only 26% of patients that were flagged as having a high risk were being referred appropriately. Why weren't all these at-risk patients being referred? So here's the slides going funny again. So our project was a Cancer Challenge of the Year project. It was funded by the Cancer Institute of New South Wales through the TCRN. And it was looking at why referrals weren't optimal and how we could change behaviour to increase those referrals. And we were using this theoretical domains framework implementation approach. What that says is it's a 6-step process. And the main thing about it is that we're using behaviour change theory, which comes from psychology, on using techniques and to systematically address the barriers. So we worked with key clinicians in the oncology, surgery, genetics and pathology departments. We used focus groups, interviews and expert panels, and we also had this validated questionnaire, the Influences on Patient Safety Behaviours questionnaire, to find out why referrals might not be being made. So it only takes 5 minutes, this questionnaire, but again, it's based on behaviour change theory. So these are telling you about not the results yet. So we invited 71 staff members to take part who were identified by their heads of department as having a role in managing patients with colorectal cancer. So whether they actually referred patients themselves or whether they had a supporting role. Now the response rate was 51% across the 2 hospitals. Most of the people that didn't fill it in were people that were rotating through oncology and were probably thought that it didn't necessarily apply to them. But the majority of respondents were medical officers and pathologists, with the rest from nursing, genetics and administration. So we were happy that we got a good spread of people represented. Just under half, so 44%, had responsibility to refer, so they were the ones actually making the decision to refer. And 69% were familiar with the referral criteria, which is EVQ. So here's where the theory comes in. The questionnaire groups the barriers into domains, so behaviour change domains. So for example, environmental context and resources domain groups together all those barriers that are around lack of necessary resources, not having equipment, verbal and written communication not being supportive of making referrals, that sort of thing. So here are the results. The top 4 barriers, which were then confirmed by focus groups, were in these domains. So environmental context and resources was the top one. So there were problems around the availability and flexibility of referral forms, which were at that stage were all paper referral forms. There were difficulties with tracking referrals, so you'd fax off your referral to the hereditary cancer clinic, and then there's no way to check whether they actually got it. There was no way to track how the appointment had been made yet, or whether someone else had already referred that was in your team, or whether you needed to do it yourself. Cognitive processes, memory and decision making was another domain. So these were problems around the timing of test results and competing priorities, bumping the discussion about whether you should be referring them to genetics or not, to a later date, and then perhaps it being overlooked altogether. Skills was another domain. So some registrars were missing out on training on how to just talk to patients about what their genetic risk might be. And some people really didn't know how they were supposed to make a referral, so that was another gap. And finally, beliefs about capabilities was a barrier. So confusing report wording, where non-staining was negative or positive, people got very confused about the wording and it wasn't consistent. So that made the decision to refer more complicated than it needed to be. Of equal interest was what were not barriers. So knowledge was not a barrier. So there was high agreement with the EVQ guidelines, and people agreed that it was important to review. There was no lack of conviction, and people were clear about what their role was. Now, the beauty of grouping barriers by domains is that then they can be matched to behaviour change techniques, so proven strategies to address those types of issues. And it means that you can be sure that you're addressing the issues in a systematic and sound way. So, for example, one barrier we found, as I mentioned before, was this one about referrals just slipping off the radar. Because there's so many competing priorities, so many things that you've got to pack into that consult, it's very easy to overlook that you haven't actually reviewed the screening test results or discussed genetic referral. So one of the groups is looking at adding a genetics field to the GP letter, so that acts as a prompt to remind them. So changing theory can be hard, but watch this space for our next audit results. Thank you.